Total extraperitoneal access for robotic assisted radical prostatectomy (RARP) for localized carcinoma of the prostate. This patient is a high-risk patient, 67-year-old male with high BP on triple antihypertensives, and he had a TRP done for a hematuria. PSMA PET showed a pulmonary embolism in the left pulmonary artery, and there was on the right lower limb full venous up to the iliac thrombus. The advantage in these kind of cases is you don't have to give a steep Trendelenburg position like in the transperitoneal robotic assisted radical prostatectomy. This Trendelenburg position is 15 degree, but the creation of extraperitoneal space needs little experience. We usually create the camera port as in the picture, slightly above and 1 to 2 centimeter lateral, either right side or left side of the umbilicus. To make a transverse incision, you can identify anterior rectus, split the rectus muscle, you can see the posterior rectus. Posterior rectus, you can take 2 stitches initially itself, which will be helpful in closing at the after the procedure. Then once you go with a finger guided dissection in the anterior aspect of the rectus fascia and up to the arcuate ligament, below that it will be the peritoneum alone in front of the bladder. After creating the camera port, either with the finger dissection initially, then you can use the telescope itself with the camera dissection just anterior to the peritoneum. You can create the space by gentle movement, but the chance of breaching the peritoneum is high. Or else you can use a balloon for a space creator. You can put the balloon in the preperitoneal space and create either on the right side, lateral, and left side, and the midline space creation. Then a midline incision can be made and make a 5 mm laparoscopic trocar, and on either side you can drop down the peritoneum and you can place the foreport. The assistant port can be made between the camera and the first right side or left side port. And the fourth arm can be made between the inferior epigastric artery and the peritoneum covering the gonadal vessels. That will be the fourth arm. Make sure that while doing the assistant ports, it is better to keep the patient in the trundle position, little more steeper, so that the bowel is not there in the nearby vicinity. And especially on the left side, the chance of injuring the sigmoid has to be taken care. Once you enter, you defatten the anterior wall, then the procedure becomes easy, like a transperitoneal approach. In this case, it's a small prostate, is a post-URP case. The vesicoprostatic junction is incised, bladder neck also is incised, then posterior bladder neck is incised along the line of the anterior incision. Vas is lifted up in the midline on either side, lift it up, then the seminal vesicle, if you are going for a nerve sparing, you have to go close to the seminal vesicles. And once both the seminal vesicles are dissected, you can lift it up with the progress. Denominus fascia is cut in the midline and make a posterior plane. The prostato-urethral junction is identified. Better to do a DVC stitch. Need not complete, but few stitches you can take with 3-0 V-lock stitch. This will give a good identification without much of a bleeding of the prostato-urethral junction. It's a small prostate, so it's easy, but the only thing is it's a post-TURP case. You have a good length of intra-abdominal urethra. The completion of the DVC can be done if you keep the DVC stitch. Make sure that you take only the DVC, not the urethra, along with that. bladder neck reconstruction is done. Ideal is to make almost the same or slightly bigger than the urethral caliber. That is the thing. This patient was discharged on the next day, and he is fully continent after removal of the catheter on ninth day. But the bladder neck reconstruction has to be meticulous and slightly bigger than the urethra, which is at the distal end. You can see the urethral caliber with the catheter in situ. Both sides symmetrical. Closure is done. This is a fish mouth closure of the bladder neck. Tennis racket, if you do, sometimes it is difficult once you go the anterior wall of the uretrovesical anastomosis. So fish mouth gives a good caliber urethra, and the visualization during the reconstruction or the uretrovesical anastomosis becomes easy. Following this, the Rocco stitch is taken. The fibromuscular tissue in the retrourethral area is taken first, and general bites from the Denon-Villers fascia. 2-3 layers are taken so that a good approximation of the urethra to the bladder neck is possible. Once you take the Rocco stitch, make sure that don't pull it initially, but a gentle controlled traction of the anastomosis gives a good approximation so that the subsequent mucosa to mucosa of the urethra and to the bladder neck becomes easy. We are taking the 7 o'clock position first with 3-0 V-lock. Following that, another suture is taken to put the 6 o'clock to 5, as well as on the right side of the anastomosis. This symmetrical pulling of the two sutures symmetrically on either side gives a good mucosa to mucosa approximation and a leak-proof uretrovesical anastomosis. Doesn't make any difference whether it's extraperitoneal or transperitoneal during this phase of the reconstruction. But make sure that you take only the urethra, not the anterior DVC in the anastomosis. This patient was on triple antihypertensives and the blood thinners for pulmonary artery embolus. She was stopped only for 5 days and was supplemented with intravenous heparin, which was stopped 12 hours before the procedures.